We have another exciting day of discussions, so let's dive in with our first panel of the day on the topic of primary care workforce. We'll have Stephanie Quinn, who is from AAFP as a moderator, and Yalda Jabbarpour of the Robert Graham Center, as well as Eleni O'Donovan from Unity Health Center, Dan McCarter of ChenMed, and Lee Norman of Optum.
Thank you and good morning. I am Stephanie Quinn. I'm the Senior Vice President of Advocacy, Practice, Advancement, and Policy at the American Academy of Family Physicians. We have an exciting, if not large, panel today. And so I thought it might be helpful just to go over their background so we know who we are talking to today as we really dig in a little bit deeper around the primary care workforce, the existing workforce and those coming up. So first, I'd like to introduce Dr. Yalda Jabbarpour, who I have the pleasure of working with every day. She is our Director of Research at the Robert Graham Center at the AAFP. She is also Assistant Professor of Family Medicine at Georgetown University, and she's still a practicing physician at MedStar Spring Valley Family Medicine. Next, we have Dr. Eleni O'Donovan. She is currently the Director of Correctional Medicine and Director of Education at Unity Healthcare, which is the largest network of community health centers here in DC with 20 sites. It is also a partner training site for the Wright Center's National Family Medicine Residency Program and it's a Teaching Health Center GME program that Dr. O'Donovan herself started in 2013. Next, we have Dr. Dan McCarter. He is the National Director of Primary Care Advancement for ChenMed. Previously, he was the Market Chief Medical Officer at GenCare Senior Medical Center, and he has served in various capacities at the University of Virginia's Medical School as Vice Chair of Family Medicine for almost 3 decades. And finally, we have Dr. Lee Norman, who is currently the Senior Medical Director of Optum Kansas City. Prior to that, he served as Kansas Secretary of Health and Environment during the COVID-19 pandemic. And recently retired as a U.S. Army Colonel, previously also serving in the U.S. Air Force, and was deployed as recently as 2018 and overseeing the medical care of over 12,000 U.S. soldiers. So as you can see, I have a panel of underachievers here. And so today we're going to talk about workforce. And so I want to turn it over to Dr. Jabbarpour to talk a little bit about what her team has been working on with respect to workforce and some of the trends you're seeing.
I think it's on. Yes. All right. So workforce, it is not a small topic. It takes up most of our time at the Robert Graham Center. And when I think about workforce trends, what's changed over the last 10 years and what's contributing to that, I think it's easiest to look at it in 2 ways. Supply. So what is the workforce out there? Who are they? Where are they working? And demand. What do the patients need and how has that changed over the last 10 years? So when we talk about supply, what we're seeing is that there are less people in continuity care. So essentially, the numbers that were graduating from residency have stayed about the same. There hasn't been a huge change in the numbers of primary care physicians that are graduating from residency, but there are less in continuity care. And what I mean by that is more of our internal medicine physicians are subspecializing, more of our pediatricians are subspecializing, our family physicians are subspecializing as well. There's been a huge growth in hospitalist medicine, both in internal medicine and family medicine. There has been a growth in the market of different ways to practice primary care, whether that's working solely in urgent care, working solely for telehealth, working solely in the ER. And what happens when we have these growth of different specialties or places to work is that there are less physicians that are actually doing continuity care. Along with that, when we look at the American Board of Family Medicine data, which people who are board certified take once every 10 years, we see that there's also a decrease in the clinical FTEs over time. So less people are full-time clinical. They're going into other positions such as research, administration, et cetera. But our supply is decreasing. Is our demand decreasing? And the answer is no. The demand is absolutely not decreasing. over the last decade, we've had a growth in our population, but not only a growth in the population, we've had an aging population. What does that mean? When someone is older, they need to see the doctor more. They have more chronic diseases. So as we have an aging population, we have more of a need to see your continuity care physician. We also know that the ACA brought great changes for people in the United States. More people had access to healthcare, but more people having access to healthcare also means an increase in demand. So right now we're in a position where we have a decrease in clinical supply, but a large increase in demand. And when you take those two things together, different estimates say that we have between a deficit of 15,000 to 50,000. That's a huge range. I think the truth lies somewhere in the middle. The recent workforce analyses done by HRSA, I think, are a little bit of an undercount because they take into account all hours worked, not just clinical hours worked. And the analysis that we did at the Graham Center that showed a 50,000 person deficit in 2025 is probably a little bit overestimate since we didn't include nurse practitioners and physician assistants in those estimates. Not only is there a shortage, but we also know there's a maldistribution. So even in areas where there are physicians, they're not necessarily working in the areas of need. What do I mean by this? So we don't have physicians that are necessarily distributed in rural areas the way our population is distributed in rural areas. Family physicians in general do better at this. If there's about 5% of our population in rural areas, there's almost the same number of, same percentage of family physicians in rural areas. But primary care physicians in general, there's room to grow. Our primary care scorecard, which I'm sure I'll talk about more later, looked at the density of primary care physicians in medically underserved areas versus non-medically underserved areas. And over time, the gap between those working in medically underserved areas and non-medically underserved areas is growing. So essentially, we have less and less people working in these medically underserved areas. The other thing that we know is that the way that we're working has changed. So it used to be a decade ago, there were more primary care physicians who were owners of their own practice. They were in solo or small practices. Now we know that most family physicians that are graduating are going into employed settings. And so what does that necessarily mean? It means there can be a loss of that personal one-on-one provider. Because generally in the employed settings, what we're finding is less continuity of care with the person. Perhaps there's more there's continuity of care with the practice in general, but it's less person to person. And we know that person to person continuity of care is important for quality of care and care outcomes. We also know that employed physicians tend to have limitations in their scope of practice. So for family physicians who are trained in doing OB, prenatal care, seeing children, seeing adults, seeing geriatric patients, doing that comprehensive care, when you're in an employed setting, a lot of times that ability to practice that full scope is limited. So employed physicians are losing continuity and they're losing comprehensiveness. And those are two of the major factors that contribute to high quality primary care. We also have seen a lot of changes in how the workforce is being filled at the state level. There was some hypotheses that in areas where physicians weren't going, nurse practitioners or physician assistants were filling those gaps. In our scorecard, we actually found that where the physicians practice in terms of the state that they practice in is the same states that nurse practitioners and physician assistants practice in. So those states that have low density of primary care physicians, they also have a low density of nurse practitioners and physician assistants. So the workforce tends to follow each other, which leaves a segment of the population just completely without a workforce. Additionally, recent data from the AAMC has shown that the number of applicants, of family medicine residency applicants to restrictive abortion states has fallen tremendously in the last year. So this is something that we're going to track and follow. What does that mean for restrictive states in terms of their workforce? Because as we know, family physicians provide more than just women's care. And so if they're being discouraged from practicing in those states, what does it mean for those states in the future in general? So that was a lot in terms of workforce, but hopefully it sets off the panel.
Thank you. Now, Dr. O'Donovan, you started a teaching health center, which is just a really interesting small but mighty program. I'd love for you to talk a little bit about what that model entails, how you've implemented it, and the role it's playing in the community.
Sure. So again, I'm practicing here in Washington, D.C. in a large network of federally qualified health centers. And in 2012, we were part of the second wave of funding for the Teaching Health Center GME program. And just so everybody's on the same page with that, in 2010, out of the Affordable Care Act, there was a legislation and a new funding stream through HRSA for graduate medical education, which funded teaching programs in community settings, right? Which is very different than traditional graduate medical education, where programs are funded through CMS. That funding goes to the hospital. And because the way the funding stream works and the formula for funding, it partially pays programs based on the number of hours their residents spend in the hospital. Teaching Health Center GME really changed that paradigm. So that funding stream, which is done as a HRSA grant, goes directly to the community-based setting where residents are training. And so we were able to participate in the second wave of funding. We started our program in 2013 as part of a very innovative program. We're part of a 4-site network across the country. With a centralized sponsoring institution that's actually in Pennsylvania. And this partnership enabled Unity Healthcare to welcome 18 new resident physicians in 2013. And since that time, so now we're in 2023, so we're celebrating our 10th year of having this program. We've graduated to date 36 physicians and been able to retain 22 of them in our own network. And that sort of exceeds the data and the expectations for this program. So overall, teaching health centers retain 56% of those graduates in FQHC and community-based settings. Okay, so that's compared to well under 20% in traditionally funded family medicine programs. So this program is really a game changer. We know that, so currently there are, I think it's 72 programs in 24 states in the District of Columbia. Right now, teaching health center residents care for over 1 million patients annually in these underserved settings. A lot of these programs are in rural areas, but they're also in urban underserved. And I think this is really a story about training in place. So what do we know about residency training in general? We know that in general, graduates stay within 100 miles of where they trained. And we can certainly, as human beings, understand why. It's a formative part. Often you're in your 20s or your early 30s, you're creating friendships. You might meet your partner or bring your partner. A lot of, over half of graduates now in primary care are women. A lot of them start their childbearing years during residency, and they're establishing those roots. And so if we're bringing these physicians to these settings, a lot of them are going to stay because that's the way life works. So we've really benefited from that at Unity Healthcare. Although obviously things happen, people go home to be where their aging parents are and things like that. To date, we still have 17 of those 22 working. And I can talk from very personal level as the director of education and somebody who provides care to inmates at the DC jail. To date, I've been able to bring 5 of those graduates to the jail to do that work with me. So on a very local level, the impact there is really tremendous. The other point I'd love to make about teaching health center GME is we know that for minority patients across the country, it is URM and minority physicians that really create that safety net and access for those patients. We also know that in federally qualified health centers, we tend to have a more diverse workforce than other employed settings for physicians. And so we're able to attract a higher level, I think, of diversity into those training locations because we look like our residency applicants often. When they look at our settings, look at those federally qualified health centers that are now clinical learning environments, they're seeing diversity. They're seeing diversity in leadership. They're seeing diversity in workforce, in the staff, because those places tend to try and hire staff that look like the patients. And so we're also starting to transform those educational spaces. And I think we're able to attract a more diverse applicant pool because of that.
That's great. Thank you. Dr. McCarter, we talked a lot yesterday about the payment system and how we have to get payment in primary care right. And that obviously goes a long way to support the workforce. But can you talk about how you might deploy those additional resources through shared savings or other mechanisms to really enhance the primary care physician's experience in practice?
Absolutely. And I think we shouldn't lose sight of the fact it's not only the primary care physician's experience. You're worried about the staff and also the patient, so they have good experience as well. So at ChenMed, we do a full risk model for Medicare Advantage patients. We focus on areas with high density, low income, underserved seniors. And the interesting thing is, because we get access to the entire healthcare dollar, not just 5 cents on the dollar, we get to decide, we get to help decide how that money is spent, right? The patients obviously have a big impact on that. But by doing that, we're able to cap panels at 400 patients per PCP. We're able to provide a team that includes not only their medical assistant, a scheduler, a referral coordinator who both helps make the appointments with the appropriate specialist, but then make sure we get the records back for that. We have pharmacy techs. We do physician dispensing. We have social work to help with both behavioral health and community issues. We have acupuncture in every center. And then we also offer cardiology as part of our primary care model, just because we have so many people in those communities who have heart failure, hypertension, coronary disease to do that. So it's listening to you talk, it's interesting. I don't think the doctors are looking for easy jobs, right? They're looking for jobs where they feel like they can make a difference. And at ChenMed, we're always looking for good doctors, but we also turn down 3 out of 4 doctors who apply for jobs with us because we want to make sure they want to do the work. It's not that they're not in love with the idea of doing the work. They actually really want to do the work that comes from that. So I think the important thing is realizing everybody can't go to a full risk model. It takes a lot of work. And if you're in fee for service, I think what the payers need to help is, one, creating prospective payment that allows practices to start building these teams. And you're going to build them one position at a time. You're not going to go out and hire 5 different job profiles all at once. But then when you create savings, instead of that money being used to cover the losses from the other part of the health system, because you're decreasing demand, make sure that savings is the primary care physicians have the ability to help redeploy those funds for how primary care should be delivered. and to build those teams. Otherwise, you could easily see that if you're decreasing the need for proceduralists and those are seen as losses, that money could be absorbed elsewhere in the system. So I think that's really important. Money is necessary, but it's not sufficient. We really do need to give primary care physicians a place where they feel like they can make a difference and they're respected. And so I think that's important. The doctors you're looking for, the doctors we're looking for aren't looking for easy jobs.
I appreciate that. Dr. Norman, you were in the thick of it during the COVID-19 pandemic as Secretary of Health and Environment in Kansas, and also in your time in the military. What have you learned about building a resilient primary care workforce?
Yeah, great question. Thank you. I've actually had 4 careers, and I've been fortunate. One is as a family physician for over 40 years. Second is military. I've been both Army and Air Force, and ultimately retired from the Army and had my most recent deployment was in 2017 and 2018. I came back and as pointed out, was on Governor Kelly's cabinet for 3 years. And additionally, for 26 years at 2 different locations, large academic centers, was chief medical officer at Swedish Health System in Seattle, and then more recently at the University of Kansas. And there's a couple of things that come to mind when it comes to the workforce. How do we shape the workforce? How do we sustain the workforce? And during the COVID pandemic was a great example. Kansas has 105 counties, not only rural, but frontier. But we also have urban areas. And one of the things we knew at the very beginning was that if we let nature take its course with testing equipment and materials, with vaccines, with therapeutics, that it was going to go to the more affluent counties. So what our decision early on was, on a per capita basis, push all this stuff out to 105 counties. And the governor said, you realize the legislature, a very red legislature with a Democrat governor, she said, that you realize that you're going to get creamed by the legislature and by the press. And I said, yeah, I know that. But the reason I bring this up is it meant looking at outcomes disparity and looking at disadvantaged communities. We had to make a very active choice to push it out there, and to push it out with people who could speak the same language, had understanding of the community, knew transportation routes and the like. So we had to, before the first case even arrived, we had already put together a plan to match people and workforce with what were going to be the needs in those communities, because one of our counties was at the 105 out of 105 counties in terms of the health status indicators. We knew that was going to be a problem. So outcomes disparity, we knew was going to drive so much. And how do we manage the workforce? Secondly, is about resiliency. One of the things that I learned long ago is you can't teach and learn resiliency in a PowerPoint presentation that basically the punchline slide is go out and be happy. You have to build systems around your workforce and practice in a workforce that you have. And I know this goes against my 26 years of management experience and training, redundancy. Because if you don't have, I call it desired redundancy, you have to build systems where people can cover for each other. And this really showed itself during COVID. I know that I personally worked every day for 100 weeks, not 100 days, every day for 100 weeks. And our incident command team was very careful about providing backup and support for the 60 of us that served on the front lines with that. And it, without question, it took its toll. But I think the desired redundancy in the system, even though we couldn't afford it, we were spending money we didn't have, was necessary. To your point, Dan, I think that there's enough money in the system that we have to look at sustaining workforces, because as we talk about 20% reduction of our nursing staff by 2027, and as we talk about burnout, then those are things that we have to pay attention to, and we have to pay attention to it now. The third primary learned lesson from these various experiences is teamwork. And we heard a little bit about this yesterday with various kinds of providers, how we're using nurse practitioners differently, how we're using community health workers. And we really relied heavily. Matter of fact, on my watch as secretary, we developed a training sequence and certification process to recognize and identify community health workers as key members of the team. It elevated their stature, it elevated their pay, and has also resulted in a training method so that people look at that and say, well, if I can do that, I can go become an LPN or an RN or a pharmacist or a respiratory therapist. So I think it's really critical to look at our workforce composition and how do we develop teams that meet the needs of these various people. I testified in front of the legislature many times on expanding the scope of practice of nurse practitioners in the state of Kansas. This went against some of our professional societies because, and I didn't provide testimony in that saying is going to be the solution to maldistribution of primary care providers. But I just said that it will make more efficient use of their time and make it so that physician time was less spent providing supervision, probably to people who don't need it. And it couldn't be more different. I live on the state line between Kansas and Missouri, and Kansas has a dramatic, the nurse practitioners are independent practitioners. And on the Missouri side, it's 180 degrees different than that. And I can guarantee you that working on both sides of the state line is different because of that. So I guess in summary, from the workforce perspective, one is diversity, equity, inclusion, outcomes disparity. We have to match the workforce with that. Because people aren't naturally, to your point, Dr. O'Donovan, people don't naturally gravitate to that unless we make it a very active process. And then the second, of course, is resilience and how you build your team to support resiliency, because we want people to stay in the trenches and continue to work longer.
Thank you so much. You all talked a little bit about what the community needs are. What are the gaps in how medical students are being educated relative to what the emerging needs are? I mean, when you all went through medical school, AI wasn't a thing, telehealth wasn't a thing. How do we build kind of ongoing learning and evolution for our upcoming workforce?
I think before we even get to the gaps and how technology is changing, one of the major gaps that we know of in terms of how medical students are being trained and what's needed in the workforce is where medical students are being trained. So we know that most of the care in the United States for people happens in the community, in the outpatient clinic. Most of the training of medical students is happening in large academic medical centers, large hospitals, maybe the ER. Many United States citizens will never be hospitalized in a large academic medical center, but that's where we're training. And so when you go out into the community, it's a shock, right? Because that's not where you're used to training. We also know that people tend to choose to choose to work in the settings that they're trained. So if we have a primary care workforce problem, it's probably because we're training in settings that are not the same as where the primary care workforce is actually working.
I would also build on that to say that if the technology and the resources gets concentrated in those academic health centers, if depending on kind of how legislation and funding and research goes, students will also be more there's going to be this kind of iterative thing, right? Where students are going to be more attracted to those spaces because that's where the cutting edge technology is. So the more that we can, leverage different programs and think about some more supporting primary care and community sites to leverage IT, to leverage AI, to become learning communities, we're going to see more attraction of students, I think, into those spaces. But we tend to get a little bit left behind, right? Things kind of roll downhill. And it can take a long time for those things to get out of those academic spaces and into the communities. So I think to Yalda's point, we need to get students out into those spaces. We need to get technology, but we need to get the right type of technology and the support and the funding for that technology. So it's going to have to happen together, I think. The other thing I would say about those training students in those community spaces, there are some sort of landmark or really innovative programs that I would highlight. One is A.T. Still University, which is an osteopathic medical school in Arizona. And their model is to take students for their first year of education on campus. And then for the subsequent 3 years, they partner with community health centers across the country, and their students choose one of those sites, and they do their second, third, and fourth years of medical school at the FQHC. And the school provides distance resources. They leverage technology to support and educate the students throughout those years 2, 3, and 4. Not surprisingly, SOMA, the School of Medicine in Arizona, has a higher proportion of students who choose to choose residencies that are in similar settings, and then they go on to practice in those settings. But I would just highlight that school and other schools and programs like it as the direction we need to go in to get students out into those spaces.
And I think when it comes to thinking about population health, thinking about how to care for the patient that's not right in front of you, we have the training that many of our residents go through is training in fixing problems, not preventing problems. So how we focus on moving from the episodic reactive care to the proactive relational care, and not be subjected to the whims of administrators who want to generate efficiency, and the widget they're producing is office visits rather than healthy outcomes. So I think at some level, the primary care physicians and the educators have to look at how to take back the care of the patients that are serving as a model for these learners to then go out and practice going forward. So I think that's important. I think there's some positive changes the AAMC making in the GME requirements, but I think it looks good on paper. Now it's got to be implemented to do it correctly.
Well, and even what you said about team-based care, even learning to identify what your practice needs or what your patients need is a skill that has to be learned.
Right, and how to relate to other members of the team.
Mm-hmm.
I can remember, you know how things will fix in your head. I can remember as a medical student getting on the elevator to hospital and a surgery resident looking at me and just out of the blue saying, if you want something done right, you've got to do it yourself. And he was obviously frustrated because a team member hadn't done something correctly. But the answer is, if you want something done right and somebody hasn't done it right, how do we look to see where the breakdown was and fix the system? It's not that I'm going to do it all myself, because that's a recipe for burnout, right?
Yeah, agree.
49 years ago, something happened, and that was I joined the American Academy of Family Physicians as a student member. So next year will be my golden jubilee. And then the other was I started medical school that same year at the University of Minnesota Duluth branch. I was in the second class, and it was stood up specifically for training physicians to go into rural and primary care areas, but especially rural areas. And it was a very fortunate choice on my part, because it helped to cast my future in so many regards with what you talked about, Dr. O'Donovan, was early experiences and not being intimidated by what is out there in the more rural and primary care world. Okay, run the tape forward a few decades now. My mantra as secretary during the pandemic was, let's not let a perfectly good pandemic go to waste. And by that, what I meant was, we have to do things differently, both in terms of distributing our resources, meaning people and stuff, but we have to think differently. I ran the Medicaid program too. That was part of my job as secretary. And we had 3 Medicaid contractors. And I pulled the leadership in very early on and said, you are going to have to spend money. You're going to have to be creative. You're going to have to do things differently. The shackles are off you. And I want you to invent things that will stay in perpetuity because they will be shown to be beneficial. And one of those that came out of it was telehealth. I'll put it broadly under that. And it meant going out and training people to use devices and that kind of thing. To Dan's point earlier, a lot of the population that was at risk were older and maybe a little bit technologically adverse. And in a lot of the rural areas, we had bandwidth problems, which are still yet to be solved. Okay, one of the things I do now is I'm in my second 4-year term on what's called the Defense Health Board that advises the United States Secretary of Defense on health matters. We've done some really important work, but the most recent one was on telehealth worldwide. As I was talking about with one of our colleagues last night, when I was in my last appointment, I had a simple question as, can you get rabies from a hedgehog? Which may sound like a light switch, yes or no, but it was fun to dial up a friend. Now through communications, I'll say, a little bit difficult in a kind of a dangerous environment. So you have to be a little careful. We finished our report to the secretary. He's accepted it, and it will be declassified and will be put out there. Very comprehensive look at all the geographies globally, which includes the United States, and as to what are the ranges of possibilities. Where are we strong? Where are we weak? Where do we need to start looking different? So that's something I think we can look forward to, and hopefully that will be declassified and available pretty soon. I know it will be published.
Can you get rabies from a hedgehog? Yeah. We all want to know.
I don't know. I just want to tease you. The answer is yes. People have actually died from rabies from hedgehogs.
I'm sorry to hear that. So, a lot of our efforts are targeted around assumptions that we get from HRSA's workforce modeling and projections. Can you talk a little bit about the methodology and what some of those limitations might be?
Yeah, I'm not the expert in their workforce methodology, but I started reading up on their methods only because, the numbers are so wide. Is it 15,000 deficit? Is it no deficit? Is it 50,000 deficit? So I really just wanted to see what they were doing differently than us. The way I understand it is that the way they counted a physician was via a survey where they asked people, how many hours do you work? Not how many clinical hours, but how many hours do you work total? And then counted FTEs based on that. So for example, I may work 60 hours a week, but I only see patients 1 day a week, so 8 hours a week. I would actually be counted as a 1.2 FTE. And so I think they are overestimating the supply because of that, because it doesn't matter how many hours I work to patient needs. It matters how many hours I'm seeing patients.
Yeah.
So I think that's the big thing that we need to look at and understand, why that was done. Was it just a methodologic reason? It was easier that way, and what better data sources we might have to actually estimate clinical FTEs when we're looking at workforce. Because like I said earlier, we know over time, people in general have reduced their clinical FTEs. So if we have the same number of bodies, we actually have less ability to see patients.
And I think that's important. I mean, we hear anecdotally that a lot of physicians are pursuing non-clinical careers, medical directors, CMO type roles. And so if they're being captured as representative of the workforce and we're targeting resources based on those assumptions, that can be very challenging. So I'm going to throw this one out there. How do you think we should measure our effectiveness of all of these efforts around workforce, either those coming up or the existing workforce? Does anyone have any thoughts?
I don't have a perfect answer, but I think a couple things. One is we use turnover as a very crude measure and have always used that. We know that 20% of new employees will not stay more than a year, and it usually is because of the relationship with their immediate supervisor. And so I think one of the things that we need to do is and that's churn, and maybe they go someplace else and live happily ever after. But I think it points out to me that what we really need to do is focus on new employees and the dynamics of the environment in their first year of whatever kind of practice it is. The second thing is, and this is a relatively new term to me, but I think a lot about it, is quiet quitting. How do we take the pulse of, how do we assess the efficiency and contentedness with their work setting? And you have to have either personal interactions and interviews specifically targeted toward that, or a really good methodology to know, is quiet quitting, meaning just low energy, demotivation in their work, and therefore it calls out what are the productivity measures. And I'm not talking about necessarily those things RVUs and churn, but what should that person be doing? How happy are they doing it? And then finally, and I've read a fair amount on this, mostly in the nursing literature, is about intention to quit, or intention to retire, or intention to resign within the next X number of years. And I think it's really important to follow the beat to beat of where our various kinds of people are in our workforce, and that they're in their chairs at their computer doesn't necessarily mean that it's an effective use of them. So we have to stay very close, and I think continue to measure, and then to back to the resiliency question, to sustain them in their work.
I think that's important. I mean, in a lot of instances, they're acting as a manager of people. And if those are not skills that they have, then they may not be equipped to have those conversations, to evaluate performance, engagement, things like that. That's a really good point.
And I hadn't really thought about it, but what about Net Promoter Score for physicians? I mean, we do the patient satisfaction surveys, and we know that patients who are satisfied with their care tend to get better outcomes. I would think that if physicians are satisfied with their jobs, it's likely that patients would get better outcomes too. And I don't know that it has to be terribly complicated, but I don't know that it's easy to do either. I'm not a researcher.
I think one thing that, we've been talking about provider-facing measures or workforce-facing measures. I think one way to evaluate how well we're doing in the workforce is some patient-facing measures as well. And before we even get complicated into patient satisfaction, patient trust in their physician, how patients feel the quality of their health is, even simple things like what % of our population actually has a primary care provider? What % of our population has a primary care person versus a primary care place? And does that differ based on who you are and where you live? So in medically underserved areas, however you define that, what % of patients in those areas say that they have a primary care provider? What % of patients in non-medically underserved areas? We can look at different races, different insurance coverage, different gender. So it's just even getting at those simple measures, which we tried to do in the scorecard, our primary care scorecard, is really difficult. We don't have a great way of collecting that data on a national basis, let alone a state or local level. So looking at those measures first, I think, is important.
Agree. And also the level of investment of a given state or area in primary care. I mean, I think that certainly goes a long way. Before I open it up to the audience, I want to give us an opportunity to land on a high note. What gives you hope about the future of the primary care workforce? Don't all answer at once. Something.
Well, no, I think the people who go to work every day and are engaged with the work and see purpose in it, I think that is huge. I think the people who go to work in the prisons every day, go to work in the neediest areas, they're finding that to give them joy in their life and satisfaction in their work. I know we've talked some about AI. I mean, I think AI has tremendous potential if we can work with it to support the primary care physicians to take off some of the administrative burdens and help them create the time to have the relationships with patients that they want to do. That is fantastic. If we view AI as a way to create more bills, the way a lot of the medical computing has been done so far, I don't think that's going to be helpful. And if we view it as a replacement of the primary care physician, which I'm sure there will be some people think that we can, like some of the customer service at the airlines is now replaced by AI, think we can do that for primary care. I think that's a mistake, because even if you know the right things to do, you need that human relationship to be able to have that discussion one-on-one to help the individual make a decision about what the right care for them is.
You know, I would also just go back to some of the programming and initiatives that have happened on the local and the state and the federal level. You know, right now we're trying to figure out the next iteration of THC GME. Hopefully we're going to get 6 years this time instead of 3 years. That's on the table right now. Hopefully, fingers crossed, we'll be able to increase the per resident amount. We can put in more planning funding so that more programs can open. But I think that's enormously hopeful. These programs work. We have the data to show that they work, that we've certainly made the workforce case. I think now we're looking more at the quality of care and what that looks like. And to me, that's the next case to make for these programs. I think the other thing, and I would just echo what was just said about mission. The THC GME was created with a mission to increase the number of primary care physicians and to increase the number of primary care physicians that work in underserved areas. It's written into the legislation. I think programs that do that, have that kind of mission built in, are incredibly powerful. And it does give me hope. The residents that we match into our program and that these community-based training programs match have that mission. And they're really in it, as was pointed out, really not for the money. Although it gives me hope that we're at least moving the needle on value-based payment, and hopefully we're matching physicians over time into systems that value them differently, because that's what's going to keep them buoyed throughout their careers.
I think a simple thing that gives me hope is that we're seeing much greater diversity in the primary care workforce. We have a long way to go. It's not perfect, but just looking at the data over the last decade and how much it's grown, both in racial, gender, rural diversity of the workforce, I think is important, because if you can bring different voices to the table, voices that haven't been at the table for years, then maybe we can actually find a solution to what's going on in primary care.
I touched on it earlier, but I think, we've gone through a tough time here really since 2020 and with the pandemic and some other things that have happened. But I think one of the things that's coming out of this, I touched on earlier, is about teamwork. And I think we're becoming a lot more creative about what is a team, what does it take to form a team, how can the team become largely self-directed and sustained and resilient. And I really hope that we take these learned lessons and that they don't somehow just get lost in the shuffle. I appreciate Dan's optimism about changing payment systems that can support teams. I hope it gets the savings that come to us because of decreasing the medical expense and cost of care. I hope that some of that is pushed back into the primary care teams, so that what can really buy, I think, is more time, so people can spend more time with their patients. And one of my reasons for optimism is I have seen that work.
I'm going to play Pollyanna and play the glad game for a second, but I think what makes me really hopeful are actually forums like this. I mean, we have very thoughtful people that are thinking about primary care, that are talking about primary care. We have the interests of employers, we have payers, we have physicians, we have patients. I mean, really all corners talking and thinking about this. And so I am hopeful that, we will make some meaningful progress soon. With that, I would like to open it up to any questions in the audience. We have one here. I think we need to get you a mic. Oh, for the people online.
Hello. Hey, I'm Kenneth, direct primary care physician. In 2018, which is when I graduated medical school, the AAFP put out a 25 by 30 initiative, which is to get 25% of USMD students applying into family medicine by 2030. Since that time, the number of USMD students has decreased by 10%. At that time, it was about 12% going into it. Now we're around 6 to 7%. And I guess my question is, what lessons have we learned from the first 6 years that we can apply to the next 6 years to try to reverse this trend?
That's a really good question. I think obviously our learning is always iterative. I think the nature of education has changed. I mean, some of the new ACGME requirements. I mean, I don't know if you have any thoughts based on your work, Yalda.
Not based on my research work, but based on working with medical students, I think that as a primary care community, or voices for primary care, we need to stop focusing on what is wrong with primary care and start focusing on what is right with primary care. I think for a long time, we've been sending the message, talking about it in medical settings. Primary care is underpaid, undervalued. Yes, we understand that. But what are the good things about primary care? Because as you know, as a recent graduate, medical students really latch on to the positive. When they see a lifestyle of a physician that is the kind of lifestyle they imagine themselves living, that they're happy, that they're valued, they're going to go towards that. It doesn't matter, what the science is, how interesting the science is. It really is about how much the person feels valued. And I think there are wonderful things about primary care that are unique, and we need to start spreading those messages, focusing on those things with less focus on the negative.
I think we're also getting smarter about different practice types and, how students are being prepared and interested. There may be certain settings that just call to more people than others, and really differentiating what those lifestyle factors are. And, so I think just as an organization, we're thinking more broadly about the different practice types and different community needs and making sure that we're resourcing our members accordingly.
I think it's really important to realize that it's hard to change an overall narrative. I think it's important that we do everything we can, but I think it's really important that we have primary care people in leadership positions so we can demonstrate what primary care physicians can do, not just on the day-to-day granular work of seeing patients, which is honorable and critical and important to what we do, but also in our leadership roles so that people can say, so family physicians can actually lead, and not just be quiet little forces out there in our little respective nooks and crannies. I mentioned I've been a CMO for 26 years, Swedish health system in Seattle, largest medical staff on the west coast of North America. And in 1991, I can guarantee you, they said, what do we have a family physician doing as a CMO of this large academic medical center? Run the tape forward to 2007 when I took the same position at the University of Kansas Health System. They said, and some of my colleagues in the first year pushed back and said, what do we have with a family doc in a very pivotal role in this academic medical center? But we can train and we can learn to be in those leadership positions because we mentor and we demonstrate strength by doing that.
Are there any other questions? Oh, we have a second question. All right.
The second one. I still have the mic. So one of the things I think, Lee, you brought up in terms of forming teams, and you mentioned nurse practitioners. I'm not trying to be controversial with the question, but so I had considered emergency medicine before going into family medicine. And when I switched, all the doctors, including some of the hospital administration, told me that family medicine, primary care is for nurse practitioners and PAs, and I was making a mistake going into it. So with the growth of the nurse practitioner workforce into primary care, how do we craft a message that's a lot more positive? And really, what is the role of the physician in that team? And what do we tell med students about it?
I go back to, 40 years ago, almost 40 years ago when I was a medical student. and thinking about family medicine, and people were telling me, you don't want to go into family medicine. All you're going to see is earaches and sore throats. And I can tell you over a 30-year career, I would kill for a day of all earaches and sore throats. So they just never materialize. So the issue is really about being that first contact care that's continuous and comprehensive, and being able to, we need our nurse practitioners. And honestly, I think we need to improve the training of nurse practitioners. There's very little funding for nurse practitioners to be trained in the communities. And we honestly need to, instead of trying to stop them or stop the PAs from being able to get the training, we need to lean into that and help them do that. But physicians still need to stand up and take the leadership that we need to create the systems that are going to deliver the outcomes our society needs. We need to train more in leadership, right? I mean, it is important to learn about leadership, and it's not just a matter of having the title of being a leader. It's how do you develop the relationships and influence people to do the things that they need to do. So I think there's so much that can be done, but we need to look at the bright spots, and some of them are being done in the community training centers. And I think that's imperative that we continue to do that.
I think this also goes back to scope, which was mentioned earlier in the conversation. We really have to fight on our sort of organizational level, in our academic centers, in our training environments, and within our organizations for family physicians, for primary care. But I think particularly in family medicine, to retain that scope, because that actually is a broader basket of skills and training to bring to the table. I think we can do more if we retain more of that scope, actually, than nurse practitioners. It does differentiate physicians. I think students are looking for that. And it does, for that reason, often put us in charge of those primary care teams. So it is more about, it's a lot more about whether you, the nurse practitioner, and I can both treat CHF. I think with the right training, we can both competently treat CHF, or most cases of it. But there's a whole other level of training, of clinical diagnosis, of thinking, and we do have to really reiterate that in the way we train physicians, and then create these systems that I think support people to really practice at the top of their licenses and training.
Well, I want to be respectful of everyone's time, and I want to thank our panel. Really appreciate your thoughts today and taking time away from all of your roles to be here. So thank you, everyone.